Well, thank you for the invite. I'm happy to be here. Good to see some familiar faces. So I'll be talking about heart transplant. I'll try to make it as relevant as possible to PA. Um, I have some biases. I am an adult heart transplant surgeon. So when someone comes to me, they have already had PA. They've had the heart damage from PA, and they're in their adult years. So that gives me a unique view of this patient population or of this group of people that I see. So they're usually above the age of 18. They've had the disease and they've had heart damage from the disease to the point where a heart transplant is a consideration. And so when I get involved, they have the heart damage and we're considering them for a heart transplant at the time of their liver transplant. So a two organ transplant operation. So I wanted to go through some of the nuts and bolts of heart transplant, what to expect, what is it, and answer any questions you might have. So, just an overview, I want to talk a little bit about the history of heart transplant because I find it very fascinating, and I hope you do too. Some of the timing of when is it time to consider heart transplant? Is my heart bad enough to consider heart transplant, or do I still have other options and other things to consider? What's the transplant evaluation process like? What's the surgery like? And what's it like living with a new heart? So to start with the history, and this is more just for your entertainment, not too relevant, but interesting, and hopefully will set some of the context of some of the issues that we have with heart transplant in modern times. So how did heart transplant begin? So the father of heart transplant was Dr. Norman Shumway. He's a Michigan local, just like me. He was out in Stanford in California, and he was doing experiments on dogs in the 50s and early 60s, transplanting dog organs, hearts from one dog to another. And he was caring for them. He was trying to perfect the surgical technique and how to care for these dogs. And he had actually gotten a few dogs to live for an extended period of time, like greater than a month or so in the 50s and 60s when this was all brand new. Um, so that was in the 50s. And then a South African surgeon. So this is something that he wrote at the end of 1967. He said, "This is very small text. You're right." So the way is now clear for a trial of human heart transplantation. We feel confident that we can take appropriate care of a patient with cardiac transplant. This was in 1967. So if you think about it, there's people in this room that are older than heart transplant. So that is relatively new technology, 1967. And there was a visiting surgeon from South Africa who went to Stanford to learn about what Dr. Norman Shumway was doing. And he got a lot of the information that he was doing. And he actually was the one to perform the first transplant in South Africa just a month after that statement was written by Dr. Norman Shumway. So this was a big deal. This was a huge event in medical history. His name is Christian Barnard. This was in Cape Town, South Africa. And he had none of the background and none of the research that Dr. Norman Shumway had developed out in Stanford. So the whole world gave him credit for doing the first heart transplant, but very few people, even till modern time, understand that it was Dr. Norman Shumway in California who had did all the work and he took all the credit. So just a piece of interesting history. And this is some pictures. This is Louis Wiskanski, I think his name was. He was 55. He was a dentist in South Africa, and he got a heart transplant from this young woman who was killed in a car crash. And again, they had done none of the research. He had just taken most of the ideas from California. It was a huge press release. He was on the cover of the magazine, Time magazine, Life magazine. There's pictures with him with Princess Diana, with Muhammad Ali. He became an overnight celebrity, and he was called the surgeon who dared. And very few people understand that he took a lot of the information from heart transplant from that other guy. So what happened after that? So obviously the world got very excited with heart transplant. In 1968, 1 year later, there was 102 heart transplants performed around the world. So we went from 0 to 100 in just 1 year. But look at the next few years. It went rapidly down to, in 1971, there was only 10 done. So a lot of this shows that even though heart transplant there was a need for it, there was excitement about it, but people were not happy with how the outcomes were. People weren't surviving very long. So the initial enthusiasm kind of disappeared over the next few years. Um, and that led to this Life article that said a record of medical failure, the tragic record of heart transplants. So it was considered a medical failure in 1971. And this was some of the early issues within the 70s with heart transplant, was they didn't know how to take care for these patients. They didn't know how to manage the complications. Organ rejection was a new idea that people were beginning to understand. Immunosuppression, how to prevent your body from attacking that organ, how to detect it, and the survival was very limited. So that first patient in South Africa only survived 18 days after his transplant. Despite all the press and all the fame that it garnered, he really had very short survival. So when did heart transplant make its recovery? So the 70s was considered a dark era for heart transplant. If you look until 1983, and in the red box there I've outlined cyclosporine. And this became the first medication that really helped your body prevent attacking the new organs. And if you can see in the green line, the survival or how long people lived after the heart transplant surgery dramatically increased in the 1980s because of cyclosporin and other medications. So it was really organ rejection and immunosuppression that helped heart transplant get its way back on the map and become a viable option for people with people with heart transplant. And in the blue box is some of the medications that we use today: tacrolimus, mycophenolate, and prednisone. So this is more modern look at heart transplant. This is up until 2015. And you can see worldwide after the 80s, when cyclosporin came around, worldwide, both in adults and pediatrics, worldwide, the numbers of heart transplants exploded. It went up to almost 5,000 a year. And I want to point out here, though, that it never really passed that 5,000 mark. And the thing that limited the growth of heart transplant further was the number of donors available. So unlike the liver, we can't take it from a living person. There has to be a size match, especially in kids. It has to be small enough to fit in the chest, but big enough to provide enough cardiac output or enough support to support the patient especially as they're growing. And there's some clever ways that we in the last 2 to 3 years have been able to increase heart transplant donors by another 10% or so, which has been the first time since the 90s. Okay, timing. So when is it the right time to consider a heart transplant? These are sometimes complex decisions, especially in people with PA who have some degree of cardiomyopathy or heart damage from their PA. And will a liver transplant alone correct that, or medications, or is this something that we need to do both organs at once? And they're not always obvious. Just a word on heart failure. So heart transplant is a treatment for end-stage advanced heart failure. When you look at how heart failure progresses, it's not just a linear decline. It's as you go along, each day you're worse than you were yesterday. What you notice is that there's these moments of decompensations or flare-ups where someone with heart failure is doing well until they have an event or a decompensation, which makes them worse off than they were the day before, much worse off. So it's kind of an unpredictable, steady decline in how someone feels. And so when we're deciding when's the right time to transplant a patient, we want to do it early enough where they don't have the side effects of having a weak heart for too long, but late enough where we're not just trading another problem with heart transplant and the care that's involved with that when they could have providentially waited longer. So it can be a complex decision to decide when a heart transplant is indicated. So we look at heart failure in stages, kind of similar to cancer. There's stages A, B, C, and D. D is considered end stage or refractory, meaning refractory that other medications and treatment options have been tried and failed. People are still symptomatic. They have shorter breath. They're in and out of the hospital with flare-ups. They have symptoms at rest, not only with activity, and we call that either class 4 symptoms or stage D heart failure. And as you progress along this pyramid and you've tried all the things at the bottom, transplant is near the top for end stage patients. So when to see a specialist, a heart failure specialist, this is an acronym that came out from the American Heart Association called I Need Help. And I wanted this available in your package so that you could use this as a reference. If you're following with a general cardiologist and you have one of these things listed here, a heart function less than 35%, a low blood pressure, you're on medications, but you still don't feel well, you're in and out of the hospital, any one of these warning signs, it might be time to consider to see a cardiologist or a transplant team where something else, it doesn't mean that you're going to get transplanted right away, but to get the evaluation started and start learning more. So what is the evaluation like? I think for most solid organ transplants, for most transplants, it's a very involved process. You meet with a lot of people, you get a lot of tests, but all of that is designed to understand if you're a good candidate for the procedure and how we can alter that procedure for you. You meet with a lot of people, and I have it listed here also again for your reference. You meet with a cardiologist who specializes in heart transplant, a transplant surgeon, infectious disease, a geneticist like Dr. Z in your clinic here, a pharmacist, also social work, nutrition, especially in PA patients. Nutrition is one of our main main components of the evaluation. And there's a lot of tests, including ultrasounds, catheterizations, lab tests, and other things like that. There's an immunological evaluation to see which organs you can accept based on the antibodies that you have. And that helps us just guide the process as well. So then we meet as a group, and once you've met all these individuals and we have all the information we need, and we're asking ourselves kind of 3 questions about each patient. Is it the right time to list for a heart transplant? Are there any barriers? Are they medical? Are they surgical? Are there any social barriers? And then the final question is, what status does this patient qualify for? So you can imagine everyone that's on the heart transplant waiting list is not the same urgency for heart transplant. Some people can only wait days to weeks, and others have the luxury of time, where they're sick and they need a heart transplant, but they not as much as someone else. So UNOS, or the United Nations, I'm blanking, but UNOS, which helps us assign organs, the allocation system, they assign a category from 1 to 6 for heart transplant recipients. So that's what this looks like, and it's a busy slide. Patients who are status 1 are our highest priority. Those patients usually only wait days, maximum 1 week or so for a heart transplant. Those patients are in the hospital, in an ICU, and they're usually on mechanical pumps that are keeping their body going until a heart transplant can become available. So those are our sickest patients, and they get first access to any donor heart that becomes available. Now, if you're a status 2, which most of the patients that we've transplanted with PA have gotten transplanted at a status 2 level, that means that you are in the hospital as well, usually in an ICU, and you have a pump in, but it's not as invasive as the status 1 pumps or the ECMO pumps. And these pumps, you're awake, you're walking, you're doing rehab, but you can't leave an ICU because you have the pump in place. So that gives you a high status, but you don't have that very invasive status 1 pump in. Now, if you're at home and you're listed for a heart liver transplant and you're sick, but you're not sick enough to be in an ICU, that's that bottom box. You would be a status 5. In our current system, status 5 patients wait a long time for transplant, at least months to years. So our current system will prioritize people who are the sickest, who are in the hospital, who are on mechanical pumps to support them, and our patients who have the luxury of time and can wait a little bit longer, they get a lower status. It doesn't mean it's impossible to get a heart transplant when you're status 5, but it's just lower chance or a longer wait. I'm happy to take any questions too at the end here about this. So these are the status 2 pumps. I wanted to include these here because all of the PA patients that I've transplanted have come to transplant with these pumps. So it's something to understand. An Impella pump, this is a pump that we often insert through the right shoulder here. It goes through a wire in through the artery into the heart, and it helps these very large dilated hearts that aren't beating well to have some circulation or some forward flow. It supports your body very nicely. It's not without, it does have some complications, but we've supported patients up to 3 months with this pump as they wait for their heart transplant. And not every patient's waiting 3 months though. The intra-aortic balloon pump, can be inserted through also again through the shoulder or through the groin. And this is a pump that helps with the circulation as well. And this is an option for patients waiting status 2 in the hospital. So surgery, what to expect during the surgery and shortly after. So this is the evaluation. We get the call when, as transplant surgeons, that there's a potential donor that's available. We look at the donor, whether they're a brain dead donor or a DCD donor, and we can talk about that a little bit later. For our dual organ transplants, people are getting a heart and a kidney at the same time. We're usually going the more traditional route, which is brain dead donors. Now, you may get asked by your transplant team if you're at this point, should I consider DC? They might ask you to consider DCD, so that's why I wanted to mention it a little bit. ABO compatibility, so that has to do with your blood type. There has to be a compatibility between your blood type and the heart that you're receiving. Size match, which we've talked about. If you're a small person, you can't have a heart that's too large, or a large person have a small heart. There also is a question about whether men who have a larger cardiac output or they need more force from their heart can receive hearts from women, because a women heart may not be able to generate enough force. So we've gotten a little more less conservative in that way. But that's something to think about. The age of the heart donor is very important. That's something that we always look at. Once you're getting over the age of 45 to 50, those donors, the outcomes are not as good. We look at the cause of death and also how the heart looks and travel time. So the heart is a little bit more sensitive to time out of the body. Really at the 4 to 6 hour mark, there is heart damage. There's damage to that donor heart as it's traveling from one person to another. So and there are ways now that we can support the hearts as they travel. But that's a travel time is something, and this is travel from the donor hospital to the recipient hospital, not from where you are at home to the hospital. That travel time is less important. We can delay, like our previous speaker said, the heart team, we kind of the power with timing. So we can delay the OR and say our recipient's still coming in. So delay. That's a power we have, which we abuse often. So the traditional pathway for donors is what I call brain dead donors. This is how donors have been done for the last 30 years or more. These are donors who have no brain stem or have no brain function because of their cause of death, whether that's drug overdose or a car accident or whatever it might be, or a stroke. And so those patients, that's our more traditional pathway. Nowadays, we have something called DCD, or donation after circulatory death. And these are patients who they do not strictly meet the criteria for brain death, but they are considered terminally ill, and they and their families have decided to withdraw care and let them pass away. We can still recover hearts from those patients, but it's a little more complicated, and we have ways of supporting the heart as it travels to us to put it in. And that has allowed us, so remember that graph where the number of heart transplants per year has capped at about 5,000. We've now been able to increase that by another 500 or so, and it's still increasing year to year. So what's the surgery like? It's quite simple. You cut out the old heart. So remember, when your heart is not in your body, you still need a circulation. You need a blood flow. You need oxygenation. All the things that your heart and lungs provide. So in the top and the side of the cartoon, you can see that you're being connected to a heart-lung machine, which is supporting your heart and circulation, supporting your body and your circulation while your heart is out of your body. So we remove the heart. This is what it looks like in cartoon form. There are 5 major connections that we have to redo: the left atrium, the pulmonary artery, aorta, SVC, and IVC. So those are 5 connections that we as the surgeons sew in. So the new heart comes on, we start in the back, and we move our way forward. I'm sure there are much more talented craftsmanship in this room than me. So this is quite simple: 5 connections. You're waiting months for your transplant, and there's a lot of care after, and all I get to do is 5 suture lines. So obviously it's more involved than that, but really the surgeries are quite straightforward. And that's what it looked like at the end with the 5 suture lines. So what does recovery after a transplant look like? So most patients are staying in the ICU for at least 3 days or so, especially if they've gotten a heart liver at the same time. We try to get the breathing tube out. That's what extubation is. Try to get the breathing tube out as soon as possible. Usually you can do that the day after surgery. We're monitoring the heart function. We're starting you on the medications that prevent your body from rejecting the new organ. And whenever you're on the medications that bring your immune system down, you have to be on some kind of infection prevention. And we get those antibiotics and other medications started. You have chest drains. We work especially in the PA population. There can't be a prolonged period without calories, without nutrition. So we're very thoughtful about that, and we're getting patients mobilized and working with the therapists early. So what does life look like after a heart transplant? So caring for a new heart is involved. There's follow-up appointments, there's medications that are new. We're always balancing the risk of rejection, your ability for your heart not to attack that, or your body not to attack that organ, versus your immune system being so weak that you become at risk for infection or for cancers down the line. So that's always something that we're thinking about. There are heart biopsies involved, especially in the first year, and I'll talk more about that, and general healthy lifestyle considerations. So the medications after transplant, there are the medications that we've been talking about, the immunosuppression, the prevent infections, nutrition, and also there are medications that prevent the development of coronary disease in your new heart. So one of the main ways that a heart transplant with time may fail is the development of coronary disease or blockages in the arteries of the heart. And it's a little bit different than atherosclerosis or plaque that develops with smoking and with old age. This is unique to a transplanted heart. And we'll talk a little bit about that in a bit too. So immunosuppression, these are the three most common medications. I wanted them to be in your packet so you had a reference to them. Tacrolimus or Prograft, and that's titrated to a level in your blood, and that's a sublingual or under your tongue medication that you take. Cellcept, which is the second one, and steroids or prednisone. So heart biopsies, that's a part of your of heart transplant care, especially in the first year. A heart biopsy is an outpatient procedure. You come into the hospital for the procedure. You're awake during it. They give you maybe some light sedation. And a biopsy forceps are placed in through one of the major veins of your neck or arms and brought down into the right side of the heart, and a very tiny piece of heart muscle is taken and sent to the laboratory for analysis. It's a very safe procedure. About 95% of the time, there's no issue, and only a very serious issue, rarely, less than 1% of the time. So this is a common procedure right after the transplant, and especially for the first year. Now, once you've made it a year out of transplant, the frequency of heart biopsies is reduced dramatically, and some centers stop doing them altogether. So avoiding infections, this is an important part of post-transplant life. Washing hands, avoiding sick people, dental cleanings, keeping up with your vaccines, and general food safety. And your transplant centers and your transplant coordinators, they'll help you learn how to live with this transplant and what things to consider, but this is an important part of it. Again, we're always balancing risk of rejection and immunosuppression versus infections and developing cancers down the line. So long-term considerations with a heart transplant. So that most people, and you have to remember this is everybody, if you put everyone in a bag and say, how long do you live with a heart transplant, you're going to get a number. I'm not sure how useful that is. That number is around 12 to 15. But you have to remember that most people that are getting a heart transplant are in their 50s and 60s. The PA population is people in their, less than 30. So they have the advantage of age, but they are dual organ, meaning they're getting a heart and a liver, which increases the risk as well. So we don't have enough heart liver transplants, especially in PA, to say how long will your heart last or how long will you live? What does the data show? But this is just a general, if you look at all transplant patients, it's about 15 years. Now, I know when we know people that have lived 30 years, and we know people that never made it out of the hospital. So there's a lot of variability, and it's hard to say exactly. But we do know that after transplant, there's improved quality of life, that people are able to do more. Some things that we look at long-term after a transplant is this CAV, or cardiac allograft vasculopathy. And this is a disease that is specific to patients with heart transplant. And I have the diagram on the right there to show you that these are blockages in the arteries of the heart. which is different than plaque buildup that might happen in the normal population or with most other people. This is concentric, or this is blockages that happen around the whole artery that limit blood flow to your heart organ with time. And this is the number one cause of retransplant. So why someone would need a second heart transplant is because of this CAV. And this is something that, as you follow with your transplant center, that they monitor regularly over the years. So it's a form of chronic rejection. We don't know exactly what causes it, but since it's unique to heart transplant patients, we think it's related to the immune system and your body's rejection of that organ with time. But we have ways of treating it and monitoring it for it. Because of the medications, especially tacrolimus, there are issues with kidney damage with time, being on these medications for many years, high blood pressure, and the side effects considered associated with steroids, including diabetes, and generally just being immunosuppressed puts at risk for infections and malignancies. Now, that might sound like a lot, but you have to keep in mind people who are getting heart transplant, their alternatives are very poor. You know, the 1 year survival of most people who are being listed for transplant is less than, I mean, at 1 or 2 years is around 40% at most. So the fact that people are living long enough to have these complications is considered an amazing victory and improvement. So that, you know, that's the end of my talk. This is, you know, the journey of heart transplant. It's complex and each patient has their own different way of going about it. But thank you for the opportunity of coming and presenting and meeting you all. Thank you. Happy to take any questions. Me personally, oh, I think in the last year, 35. Yeah, yeah. Yeah, so last week was 5, so that was a busy week. But PA patients, I've only done 2. I've only done 2 in the last year. Yeah, 2. She is one of them. Yes, she is. So I will say with our PA population in specific at Cleveland, in Cleveland Clinic, we've done about 5 heart transplants in patients with PA. 4 of them were heart liver and 1 was heart alone. And all of them are doing well. The one who got a heart alone has about 12 years out from his transplant. He was 26 when he got transplanted. He's about 38, 39 now. And he was the first one. And since then, once we learned more about the disease, we haven't done heart alone for PA patients. But with close follow-up and education, he hasn't had ongoing issues. But the concern is that his new heart will be damaged by PA. So if moving forward, we've kind of abandoned that strategy and we've done dual organ heart liver transplant at the same time for PA patients. Yeah.
Very nice talking to you.
Thank you.
Did you comment what pathologic studies did you do on the hearts from the PA patients? Did you do EM? Did you do entomology?
We really haven't. That's an area we really haven't done much. I think our pathology lab and the cardiology teams are looking into that, but that's not something that we've gotten very far on.
Glad to help.
Yeah, I'd be interested in doing that.
Very good point.
Yeah.
Prediction could be that some of those hearts have a severe mitochondriopathy. And you're not going to be able to see that under conventional microscopy.
Yeah, I think that's a really important an area that's where, and we have the organs, and we might as well get the information and learn from.
Yeah.
Yeah. That would be great. That would be great. We have a few on our waiting list now that are waiting for our transplant, and we did one last month as well. And so it's something we're seeing more and more frequently, and we're trying to learn more. There's a lot of questions still, and we want to get smarter about the decisions we're making about when can we go heart alone, when can we go liver alone, is there a role for an LVAD pump in these patients or not, and just trying to learn more. And I think how will gene therapy affect things, and how does early institution of nutrition and diet changes affect things. There's just, I feel like lot to learn. And I think that would be great.
Virtual audience. One says, have you all experienced the need for heart transplant in early adulthood for a PA patient that has had a liver transplant early in life?
Yeah, so I personally have not done a heart transplant in someone who's had a prior liver from PA. You have to remember, as a heart transplant adult surgeon, my bias is that people who are seeing me have already had the heart damage, extensive heart damage to the point where they need to see me. So I'm not sure if there's a group of patients who got their liver transplant and then never progressed to the point of needing to see. So this is probably a better question for some of the other speakers. Yeah. Does anyone else have a comment about that? Yeah. So we're in the adult world, and correct me if I'm wrong, it's a whole transplant. Yeah, it's a whole organ transplant. Yeah. And we do them in the same operative stay. The heart goes first, and then the liver team goes after. Yeah.
Dr. Morton has two questions online. Question number one is, why are we doing liver heart instead of heart only? He shares that he's had 3 patients who had heart only transplants. What data do we have available suggesting the advantage of buying heart?
That's a great question. I'm not going to give you a satisfying answer. So we have done the one patient heart alone, and that's been working for him. We just don't have the numbers or the data or research to say that the concern is that if we do a heart alone, that the ongoing metabolic disturbance or the enzyme buildup or the metabolic derangements would affect the transplanted heart. And you have to remember, these are young, healthy patients. We want to give them the best chance we can for and they can tolerate these dual organ surgeries. Yeah, of course, it's more risky and there's more involved, but we feel that that's probably, and we have no data to suggest that. This is just based on experience. Usually the heart drives the immunosuppression. So those at our center, those 3 drugs that I showed, Prograf, CellCept, and steroids, will be enough immunosuppression for the liver. So it's the heart's regimen that triumphs usually. Great, thank you.